So good morning and welcome everyone. This is our 11th CTSI annual symposium. Today, the title of the symposium is Health Equity Through Translational Science, Addressing Outcomes Impacted by Social Determinants of Health. This is our first in-person symposium since, actually hybrid, I guess I should say. So hello to our folks who are on Zoom and the webinar, but I think a really nice opportunity to bring the community together, both virtually and in person. And as most people know, this symposium is held in honor of the memory of Dr. David Selden. I did not actually have the opportunity to get to know and work with Dr. Selden, but anytime his name is mentioned, people who did know him and get to work with him, they really just are very effusive about his wisdom and his passion and his commitment to this day. So Dr. Selden was a founding member of the BU CTSI. We are 15 years old. That was back in 2008. He made really critical contributions to our core facilities program, including implementing a highly innovative core voucher program. And he was best remembered in the CTSI really for being the person who brought together this day. In this clinical translational science symposium. So when we think about this symposium, all of the people who worked so hard to have this day, it's really in his memory and bears his signature. And we continue to be indebted for his wisdom and for his vision. And as part of Dr. Selden's approach, he really always wanted this day to be fun. So to Chris's point, we hope people make connections, learn things and have fun and remember his contributions. Before I tell you a little bit about the day ahead and introduce our really phenomenal keynote speaker, I do want to extend my thanks. There was a tremendous group who allowed everything that you see to be possible today. So thanks to the Symposium Planning Committee that includes Dora Green, Natalia Marone, Howard Cabral, Stephen Tringali, Liza Fuentes, Johanna Chesley, Valeda Britton, Alicia Walkman, Matthew Zuniga, Rebecca Lobb, Elia Morris. I told you this takes a village. Hubert Wong, Kayla Kufelt, Nick Trombley, Chris Shanahan, Nesreen Hajat, Scott Wilson, Corinne King, and Yorma McSquiggan. So I think we should give a round of applause. Thank you to everybody who brought this together. I also want to send a special welcome. We have some guests visiting from NCATS. We have Dr. Francisco Leyva, who is our program director. Welcome. Dr. Soju Chang, who is Chief of Initiatives and Consortium-wide Activities. Dr. Chris Hartshorn, who's Chief of the Digital and Mobile Technologies section. Dr. Christopher Bao, who is the Program Director of Small Business and Technology Program. And on Zoom, Dr. Erica Rosemond, who is Acting Deputy Director within the Division of Clinical Innovation. So now thinking about the day ahead. So today's symposium is focused on health equity through the lens of translational science. And so for folks out there who don't spend their day like we do really pondering translational science and what translational science means, the definition of translational science is the process of turning observations from research laboratories and clinics and communities into outcomes that improve health. And so how do we create the pathways and partnerships that allow things to go from bench to bedside to community more efficiently and more effectively? And I think here at the BU, CTSI, and BMC, rooted at the center of that is really thinking about health equity and how do we improve the health of all populations. So core to our approach to translational science roadblocks has been to really question the foundation on which medical science is built, which has been historically really founded on a science around white men. And so how do we really question those structures and change what medicine and science looks like? And so we strive to enhance diversity in our research teams, to engage communities as partners from the very beginning of the research question, all the way through implementation and dissemination. really identify and think about upstream solutions for social and structural drivers of health, use data to uncover inequities, and to move to collective action in terms of improving health of all populations. So we have an exciting day ahead with many incredible speakers. Kicked off, we are really honored to have our keynote speaker here, Dr. Bisola Ojikutu, who is joining us. She is a nationally recognized physician leader, health equity researcher, and community advocate. Dr. Ojikutu was appointed the executive director of Boston Public Health Commission in July of 2021. We are lucky as a city to have her in that role. In that role, she builds innovative partnerships across city departments and within Boston communities to advance equity. She also leverages decades of expertise in research and infectious disease. Dr. Ojikutu has tirelessly demonstrated her deep passion for increasing access to healthcare among structurally marginalized populations. Please join me in welcoming Dr. Ojikutu to discuss the work of the Boston Public Health Commission to move from collecting data to collective action.
Good morning. So great to be here. I'm honored to join you. I want to thank the organizing committee as well as Rebecca. And is Howard Cabral here? Is he here? Because I work with him on other things, and I know he's been very involved in a lot of this work. And I just want to thank them for their long-term commitment to working with the public health systems here in Boston and to doing the kinds of things that I think are so important that we don't do enough of, and that's bridging public health and academia, really bringing those two important institutions together so that we can move forward and actually advance health equity. So today I'm going to talk about how do we advance health equity and racial justice using data, and then moving to both collective and very intentional action. So being clear about what we're doing, not just putting programs in place, and I'll talk about a lot of the things that we do in terms of programming, but what is it that we're really doing over time to create change? So I'm going to start by reviewing data, and the data that I will review are stark, and they should disturb you. And if they don't disturb you, it's probably because we've normalized a lot of the inequities that we see in our world, but they should disturb you. Then I'm going to try to describe a bit about, like I said, the programs that we put in place and tell you why they're good and why they're not so good and why we need to do things differently. And then I'm going to shift to an area that I know a lot of you all probably have opinions about: substance use disorder, unsheltered status, and the current situation that we're working on here in Boston, the epicenter of all that in Mass and Cass. And what I'm hoping is that there'll be time for discussion. I really appreciate how this session was laid out, that this is a time to hear your thoughts. This is a time to share. There are no right answers to any of what's occurring right now in the city as well as our world. And certainly your opinion is valuable. Okay, so turning to data. So just so we're clear about the data that the Boston Public Health Commission, creates and posts online, we have this system. It's called the Health of Boston, and it's existed probably for more than 20 years. This isn't research, it's surveillance. It's giving you trends in health across our city. It's comparing trends in health across demographic groups. It's very useful in that regard. And I think a lot of people, both policymakers, programs, sometimes academic centers, use these data to inform policy and programming. Now, currently, there are 6 reports that are available online, and you can open them up and download them if you'd like. Hopefully, at some point, we're going to go to an actual dashboard. And those 6 reports are covering a lot of the key areas that we think are important for public health, as well as just health overall in Boston. So today, because we don't have time to go over every report, what I'm going to do is talk a bit about the 2 that I think are really the most important if we want to understand health and well-being in our city health and well-being in our state, health and well-being across countries, there are really two measures that we look at, and that's life expectancy and then infant mortality. So those are the two things I'm going to focus in on. But certainly, as I said, please take a look at the others and realize that there are going to be reports on substance use disorder, there are going to be reports on violence, there will be reports on community assets, and a number of other areas will be posted by the end of this year. So starting with life expectancy. So how many people in this room have seen this data? So there's a 33-year life expectancy, Back Bay, Roxbury. Just raise your hand. Have you seen the data? Okay. So you've seen it because people have been talking about it for the last 10 plus years. These data are old. Okay. And that's an unfortunate piece of what we need to work on in terms of updating our data, making sure we know where we stand, where we need to go. So these data were published back in 2012, and they aggregated data from 2003 to 2007. And essentially they looked by census tract, which made it unique in the world, because generally it takes a lot of time and effort. Those of you who do geospatial analysis, who do any sort of environmental, work looking at space, know that it's tough looking at census tracts. Oftentimes you just don't have enough data in per census tract. So they got this data, it was published, and it made a lot of news, and it caused a lot of, I think anger from the community, concern, like, what do we do about this? And there are a lot of programs were rolled out as a result of this data. So when I was appointed in this role, one of the first things I wanted to do is take a look at where we are now. Certainly 15 to 20-year-old data could not be where things stand. We need to find out what's going on now, and we need to figure out what we need to do differently going forward. So what we did was we started at the city level. I mean, what you do is you start big and then you sort of zoom in. And we found that Boston's life expectancy over the course of 5 years, 2017 to 2021, was 80.2 years of age. Now that's good relative to other similarly sized cities around the United States. And Boston and Massachusetts tend to lead the pack in terms of similarly sized cities and states. But when you start to drill down to neighborhoods, and these neighborhoods, tens of thousands of people, upwards of 60,000 people we're talking about within neighborhoods, some of our larger neighborhoods, you see that there are differences. Now, Mattapan has the lowest life expectancy by neighborhood across Boston, and that's 77.3 years. But that's not so incredibly different than average life expectancy around Boston. It certainly wouldn't make the news media like the previous data, the 33-year age difference between Back Bay and Roxbury. But if we stop there, we're going to miss a whole lot of important stuff that should lead us to some policy change, some structural change, which I'll talk about. So we zoomed in. We went back to Back Bay and we said, what's life expectancy now in Back Bay? And we found, not surprisingly, it's still quite high in one particular census tract, 92 years. And you see, I have some social determinants of health and some race ethnicity data here. Median income greater than 140,000, college degree. Most people, adults have college degrees, 82% white. So then let's go back to Roxbury. Remember, there were the two, census tracts, two neighborhoods where we noted the extreme difference. So in Roxbury, we still have a census tract that is actually the lowest across the city. Now, this Back Bay census tract is not necessarily the highest. There are a bunch that are rather high, but we wanted to make the comparison to look at what was happening previously to what's happening now. So if you look at Roxbury, life expectancy is 69 years. Median income is, about 70% less. So it's 40,000 per year. Fewer people have college degrees, and you see, really, we're talking about people of color who live within this census tract. So it's 50% Black, African-American, and 32% Latinx. So vast difference, but not as extreme as it was before. So it was 33 years before, now it's 23 years. So what might that be telling you? Well, it could tell you, wow, we've made progress. Some change has occurred over time. That's possible. It could also mean that there's been demographic shifts. There's a lot that's happened in Boston. There's a lot that's happened in that census tract and in the surrounding census tracts. It may not be that we have made progress. What we need to do next, and I'll just tell you, I'll put a pin in this, that we're working on a deeper analysis to really understand, is this real or is there something that we're missing? Is there gentrification that's occurred here? Is there a shift in demographics? What is it that's happening here? But irrespective of all that, 23 is a big gap. And even when you look across the country, at different neighborhoods, different census tracts. 23 is pretty large. Okay, so what about COVID-19? Now, you all read the media, of course. You know that there was a lot of attention paid to the fact that COVID-19 obviously decreased life expectancy across our country, and it decreased life expectancy in various states differently in various cities. So what did it do here in Boston? So we looked pre-COVID versus during COVID, and that's where, you know, our data really ends at 2021. And what we found, that Boston as a whole lost more than 2 years in life expectancy, comparing those two time periods. But Latinx, Black, and Asian individuals lost significantly more years. So 4 years for Latinx individuals, 3.3 years for Black individuals, and 3 years for Asian individuals. Now, of course, this is a concern, but if you look at the national data, you see that we regained some of that life expectancy. So we're not sure exactly where this will go, but I think it's important to know, and we will follow it and see if we're actually going to regain those years. So anytime you're looking at life expectancy, I think one of the first things that you want to investigate is who's dying early. So looking at premature mortality. And here in these data, essentially premature mortality is dying at 65 or under. Now, people can define premature mortality in many different ways, 70, 75, however they want to do it. We use 65 and under. So here what you see is that Black individuals have essentially a significantly higher premature mortality than other groups. Other groups really haven't changed in terms of their premature mortality over this 5-year period. But what you're seeing here is that Black individuals have a 37.3% increase in premature mortality compared to other groups. Now, the first thing you should ask yourself is, why? What's going on here? What's going on here that may be different for these individuals, Black individuals, versus others? Well, the first thing we looked at was cause of death. You know, what exactly is going on in this particular population, Black African-American individuals over time. So you see 2017, 2018, it was invasive cancers. That's aggregate. 2019, cardiovascular disease. But then 2020 and 2021, we had the shift to accidents. So what does that even mean, accidents? So we went to the data, obviously looked at our definitions, and 80 to 85% of accidents are actually drug overdose. So that is what's happening in younger individuals, younger Black individuals in Boston. Now, it's not that we're not seeing that in other populations. You know, we're in the middle of a crisis. That's understood. But the extreme deaths that are occurring here, and I'll give you more data in a minute because we're going to talk about mass and cast, as I mentioned, but that's what's driving some of this premature mortality here in Boston. Okay, so let's shift gears to infant health, because as I mentioned, you know, it's really important to look at life expectancy and infant mortality. Let's start with preterm births, as well as we'll talk about low birth weights. So preterm births, that's birth before 37-week gestation. What we've seen, and this is not new, obviously the data are more recent, but if you go back in time, remember Health of Boston has been going on for 20 years. That's what I mentioned. These data have not changed significantly. You see that there is a significant difference between Black infants and all others, particularly Black infants and white infants. Now, if you turn to low birth weights, and that's less than 5.5 pounds, same thing, significant difference between Black infants and other infants. What we're talking about here with low birth weights and premature birth, these are predictors of infant mortality. So we started there. I think it's really shocking when you look at the infant mortality rate data, which I'll show next, because I think as you look back, like I said, 20 years ago, the way that things have proceeded and progressed, there really has never been a time when we've ever narrowed that gap. It's quite surprising. So here, what you're seeing is the last 5 years, and what this is showing you is Black infants have an infant mortality rate that's 3 times higher than that of white infants. It's not that this isn't seen across the country. This is true across the country in other cities. But for me, as I just take a step back and think to myself, what's going on here? What do we need to do differently? And how can we tolerate this? Okay, so I think those are the questions that I want us to ponder. because something's not quite right, especially in a city where you have so many resources, so much access. I mean, access defined as, insurance status, if you want to just use that, that is your access metric. Obviously, access is much bigger than that. When you think about it, this is very disturbing. And again, just want to emphasize that over time, for the last 20 years, this has never closed. Maybe it's been a little bit wider, maybe it's been a little bit smaller, but it's always been very concerning. Okay, so obviously what I presented should sort of lead to the moral imperative for us to change, for us to do things differently. Okay, the moral imperative. These are other, our human beings. We're all, living here on this earth together. So let's all work together to get it done. But we all know that that isn't always the case. That doesn't motivate everybody. So there's the economic imperative. And you may have seen, this was in the Globe and, covered pretty widely in the media, the economic burden due to health inequity in Massachusetts, and that's health inequity by race and ethnicity, totals $5.9 billion per year. Where does that $5.9 billion come from? Well, 1.5 avoidable healthcare spending, 1.4 lost labor productivity, higher rates of poor health, premature mortality. Well, that's actually the next one, 3 billion, but just higher rates of poor health within large populations. And then 3 billion, or just over half of this, premature death. So I talked about this issue of premature mortality. That's what's going on here. And that's something that seems to be, as I would say, motivating people currently to start to think about this in a different way. Most of you all probably have thought about this. It seems like health equity or health inequity, the interest has increased recently. And I think the interest, relates to COVID-19 and a lot of what we saw that were, those very stark, disturbing disparities. But I also think that it's when you publish data like this and people are thinking just about what this does economically to our state, to our country, if we don't realize that large populations of people are just unhealthy and we need to do something differently. Okay, so what are we doing? So Boston Public Health Commission, that's our city's, public health department. And I think we do a lot. I'll say as executive director, I think we spent a lot of time doing a lot of important work around the city. I think it's tough. It has been tough just because we do a lot of direct service. Not all health departments do a lot of direct service. And, we run the homeless shelters and, do a lot of with EMS and these sorts of things. But one of the things that I want to emphasize is that we have over 40 programs. I'm highlighting the term programs to address health inequity across our city. These are long-standing, most of them, like 30 years. So all the while we have these disparities, like that I mentioned, these gross disparities, we have these citywide programs. Now, these programs are really quite impressive. I mean, they're doing great things and are nationally recognized to do great things. One I'll tell you about, Healthy Start Systems. We have Healthy Baby, Healthy Child. I don't know how many of you all work at the hospital, but it is a important program. We meet federally with the federal providers of the funding quite frequently. We provide home visits. Other cities, states don't do that. Multiple home visits to individuals and families. And this is something that I said has been going on for like 33 years. And since 2020, 3,000 people who give birth, as well as their families, have been served. So a lot of people have been served by this program. Wonderful group of individuals leading it, wonderful program. We also have Healthy Start in Housing. So we know social determinants of health. That is what's underlying what's going on in terms of life expectancy, infant mortality. Health, I think probably all of you all know this, health is really a factor that's determined by what is happening in our communities, in our neighborhoods, not necessarily what's happening in our health systems or our hospitals. So we think about these issues of social determinants of health, and we have Healthy Start in Housing. So through this program, we have people who, are housing insecure. We provide them with housing, particularly during the time when their children are very young. We do intensive case management. We have about 50 families that are housed right now, but this is time limited. And I think I want to mention that too, that this is an important piece of this. It's time limited. So we give people, individual families, 18 months of support. After that, you have to think about, well, what happens? We do our best to find better places for them to go, but it's time limited. So we also have other supporting programs. We do things like father friendly, which means incorporating fathers in care for their kids who may not have been incorporated. We have a large food pantry that most people know about and go to. We have early childhood mental health programming that's been very important to health and well-being for young people across the city. Again, individuals, families, young folks across the city. And then we have new programming because we know that this issue of infant mortality and maternal morbidity and mortality are major issues. So we established the Boston Healthy Families Community-Based Perinatal Health Project, which is essentially a program that's focused on increasing access to doulas. And we know from the data that access to doulas increases the health and wellness of both the mother and the child, decreases low birth weight, decreases premature births, and hopefully increases or decreases infant mortality. So we're engaging, training doulas. We should be increasing the number of doulas available to individuals who give birth across the city significantly over the course of 5 years. And we're also increasing awareness of the impact of doulas. So that's great. Shifting to chronic disease programming. So here, we also do an enormous amount of work. We haven't been able to do as much work, frankly, because of COVID-19, because of the attention paid to the pandemic, these issues of infectious disease spread. We lost funding, as most people have. So there's less out there looking at cardiovascular disease, hypertension, these other critically important issues. But we've still been able to maintain certain programming. So we work with the CHCs, all 22 around Boston. We have a community health worker training program. We've trained thousands of community health workers who are now active in the city. Nutrition education, active living, fitness, asthma, you name it, there's a program that has been established to do something about it. Now, again, I think all of these programs are great. I think it's important to have these programs where we have individuals, where we have families engaged. But why haven't we fixed this? I mean, that might be part of the discussion that we have. I'm going to tell you what I think. Because like I said, millions of dollars. This is not an understatement here. We've spent a lot of money as a city to do this, to do the things that I've mentioned already. And that's just a piece of it. I didn't speak about all the things that are happening across the city in many different ways. But why haven't we fixed this? So I'm going to hypothesize that what we are doing is we're focusing on individual level interventions. We are doing programs, as I mentioned, that are time limited. They're not necessarily changing the systems, the policies, or the structures, like structural racism and other structures, that actually determine the social determinants of health, the quality and quantity of those social determinants that then impact life expectancy, infant mortality, premature mortality, chronic disease outcomes, all of that. So we're not changing things. We're not shifting the dynamic. And it's, been very interesting. I was on a panel with Alistair Bell a few weeks ago, and he said what we all know, but I like how he said it. He said, systems are designed to get the outcomes that they were designed to get. The things that are existing need to shift if we really want change. So the question is, what do you do differently? And again, I'm sure many of you all have ideas, and we can talk more about that. I'm just going to hypothesize a little bit. So what we need from my perspective, and what we're trying to do here at the city, is implement structural interventions. So structural interventions actually alter the political, social, and economic environments that create the social determinants of health. So these are the things, as I said, that will dictate and determine and characterize how individuals actually live going forward. It's not just a one-time thing. It's not an 18-month thing. It's not a 5-year thing. We're really talking about changing how people exist. I think that these interventions need to be population level. They need to be place-based. So at the census tract level, like we talked about census tract, they need to be community-led. That's oftentimes, strangely, not the case. And they need to be sustainable over time. So what are we trying to do right now? So I'm a member of the Health Equity Compact. So the Health Equity Compact is a group of about 80 leaders across Massachusetts, who most of whom are Black or brown, but it's become more diverse over time. And the group came together because, as the leader of the group, Michael Curry, who's the president of the Mass League, says, if not now, then when? If not us, then who? if you have a lot of people who really care about health equity, then they should be synergizing their efforts. That oftentimes doesn't happen in Boston either. We kind of work in silos. We do the thing over here at this institution, do the thing over there in this other institution. I think people recognize that. So I have no problem saying it. So the Health Equity Compact drafted an omnibus bill. So a huge bill. It's called an Act to Advance Health Equity. We testified about it recently at the State House. And essentially what it does a lot. This is probably just part of what it does. So one of the things that it wants to do is actually make our government, in terms of who's running things, more equitable. I don't know how effective that will necessarily be to change things, but that's one of the things that's in the bill. Hold our systems accountable, which I think is really important. So data, actually knowing what programs do. If we residents of Boston are spending millions of dollars in programming, what is it actually doing? And what should change? Thinking to ourselves, who are the providers? Are they culturally diverse? Are they linguistically diverse? All of those sorts of things are very important, and making systems accountable to some broader structure at the state level. And then, of course, looking at things like mass health, making sure there's really full coverage. We are almost a full coverage state, but really making sure everybody has coverage regardless of their immigration status, lowering the cost of medications for chronic diseases. But what I want to focus our attention on is the thing in red. So health equity zones. So myself and Elsie Tavares, the chief equity officer at MGB, we're the co-chairs of this health equity zone work group. And I want to just spend some time just talking about what that is, because I think what it does, or what I hope it will do, is it actually does shift the structures, the policies, the systems, the things that I was talking about really that do need to shift in order for us to address disparities. So health equity zones are innovative. It's a place-based approach. Essentially what it means is that you take a micro area, and that micro area may be a census tract, maybe a census block group, maybe even smaller than that. And you say, okay, who are the community members? Who are the stakeholders in that particular area? And you say, hey, stakeholders, what is it that you believe needs to change? That oftentimes doesn't happen. I mean, we have community advisory boards for different things, but really asking people, what is it that they believe needs to change, and funding them to lead that change is what health equity zones do. So it actually shifts decision-making power from institutions like the Boston Public Health Commission to communities. It supports these community-led coalitions. It funds and sustainably funds place-based strategies, and it promotes accountability and sustainability, which I think is really important. And as you listen to what I'm saying, I think that is really what we want, is sustainable initiatives, things that keep going, because we have a lot of ground to cover. Okay, another piece of what's happening here and that we're discussing very intensely at the city level is wealth. When we think about the main factor that leads to these disparities, and we go back to that social determinants of health graphic that I gave you, really it's, people call it income, and income is one way to look at it. It's not broad enough. It really is wealth. It really is how much you're making minus how much debts you have. I mean, it really is, that is the case, and that's what all the research is showing. And we know that wealth is unequally distributed across the US, and here in Boston, we know it's unequally distributed by race and ethnicity. So what we would like to do, what we're thinking about doing, which would be great to chat with folks about, is trying to create place-based, community-driven, guaranteed income programs. Now, when I say guaranteed income programs, some people look at that as like cash transfer, like to give low-income people small amounts of money. It's like the pilots that are available now is like $500 per month. And according to the pilots, people do better over time. They're able to deprioritize the other things that they're worried about and prioritize health and wellness. That's at least the theory. Now, when this came up, I think myself, other folks at the table said, yeah, but are we going to be able to sustain that? I mean, who's paying for that? And most of the pilots go for a year, 18 months, something like that. But then what I thought is that, well, wait a minute, what about wealth? Because giving them some money, that doesn't mean you're going to make them any wealthier. That's not going to fix this gap that we know is driving the disparities that we've seen. So why don't we think about economic mobility strategies? Why don't we think about how we move people along a pathway to more independence, a greater sense that they have a safety net so they can weather a financial shock? You're getting rid of their debt. Maybe it's baby bonds, which is a way that people have thought about, saving money for kids at birth and then having that accumulate and then giving them that money when they turn 18. Maybe it's expanding mortgage subsidies. Now, Mayor Wu has done a lot of that around the city. There are a lot of different things to think of, and we're kind of in our early stages of this. But I do think this is one thing that we can consider, again, as sort of a place-based strategy. So other things that we're doing. So one of the things that I was very concerned about when we got the ARPA funds, so the American Rescue Plan Act funds, and every city got them, states got them, other jurisdictions got them, was that a lot of the money was going directly to, well, all the money was going directly to city institutions, right? And how does it trickle into communities? Who's getting the money? Who can actually use it? Who can actually determine how it's used? So we created this empowerment fund, and we're shifting federal funds into community-based organizations that have a proven record of delivering in terms of building capacity within communities to do some of this work themselves. So I can't tell you more about who's actually gotten the awards because that I think it's going to be announced next week, but we have some great community-based organizations that want to be sustainably funded to do this work and to really build infrastructure so they can engage in this process with us. So this did not come out very well. I don't know what happened there, but essentially what I wanted to show here is just that part and parcel to this, it's not just about structural change, as I mentioned, not just about shifting policy, but it really is about community mobilization, community empowerment, and that is how we will create change. I do believe that that's one of the pieces that has been missing. It hasn't been sustainably invested in over time. Okay, so I want to share one thing, and then I'm going to move on to mass and CAS really briefly. I realize I think I'm at 9:30. So, okay, we are very intentional about this work, as I mentioned, and we think that it's really critical that this is part of who we are as a city, who we are as a public health department. So we've actually changed our mission statement. And maybe you all have heard our mission statement. It sort of rolls off the tongue: to protect, preserve, promote the health and well-being of Boston residents, particularly the most vulnerable. And I thought that mission statement was great. But when I sat down with my leadership team, we said, you know what, it could be better. We want to say that we want to work with communities. We want to do the protection and the promotion, but we really want to highlight what vulnerability means. It means you are impacted by systemic inequities. It means that you're impacted by structural racism. We are all impacted by these things. So we changed our mission statement to work in partnership with communities to protect and promote the health and well-being of all Boston residents, especially those impacted by racism and systemic inequities. Some people think, oh, that's just a mission statement, but it is important to change things, to actually put it in writing and say, this is what we're going to do. Hold us accountable to this. Okay, so let's turn to our example. So mass and CAS. I feel I spend probably 70% of my time on this issue, largely because it's a huge one, and I think it's a defining issue for a lot of what's happening right now. A confluence of issues have obviously come together to create what we've seen right around the corner in recent years. Obviously, the growth of fentanyl and synthetic opioids, as well as just polypharmacy in general, the housing crisis, COVID-19 pandemic, all has led to an increase in those people experiencing unsheltered homelessness. Maybe everybody doesn't recognize this, but there's certainly an overrepresentation of Black, Latinx, and Indigenous individuals experiencing substance use disorder amongst the homeless population. And we know that there's inequity in access to and distribution of services, particularly these housing pathways. Who gets on the list? Who doesn't get on the list? And treatment. If you're talking about detox, if you're talking about medication to treat opioid use disorder, we know there are disparities there, both here in Boston and nationally. And then there's this really disturbing data that came out a few months ago. There's been an increase in overdose deaths in recent years, particularly among Black and Latinx individuals. 30% of all opioid overdose deaths in Boston were amongst Black individuals, 21% were among Latinx individuals, significantly higher than amongst white individuals. And there are many reasons why this has happened. There's many. This is a problem that's affecting lots of people. Don't mistake what I'm saying. But when you see these kinds of changes, and this has really been sort of a recent shift, and even a recent shift to the demographics, down on Atkinson Street and in the quarter-mile radius here around Mass and Cass, there's been a shift. You know, if you drive through the area, that there has been a change. So back in 2021, I was appointed, the mayor was elected. This is the epicenter, Mass and Cass, you know, Mass Ave and Melnia Boulevard. So at the time, the little blue cones are the tents that were on Atkinson Street. And then there was an area around Newmarket Square, lots of other blue cones. So a larger encampment. So actually 2 points, 2 nodes that served as encampments. So at this time, when Mayor Wu came into office, she said, this is one of the defining issues of my leadership. This is a top priority. We've got to do something. We've got to do something differently. This cannot continue. So she identified several of us as leaders of this. So Monica Burrell, who was the former commissioner of the Department of Public Health, Sheila Dillon, the chief of housing, myself, in collaboration with lots of other, you know, city departments and lots of other partners across the city, took this on as something that, of course, needed to be addressed. And when I say addressed, you know, that includes a wide variety of different things that we're doing. I mean, you all probably know, you know, we sort of lead the country in harm reduction and syringe exchange, but Narcan, naloxone distribution, family reunification, lots of different work that's going on. But particularly, the mayor didn't want people living in tents anymore. Now, this is a source of, I'm sure, different opinions. What was happening then and what is happening now, lots of violence. The violence has escalated recently in the last few months, you know, people being victimized, not a good situation. And so the question is, if you have people in tents, and that's the only place that they've ever been, many of them have been for years, and you don't necessarily have a place for them to go, or at least not immediately, well, what do you do? So there was many sessions, many powwows to figure out what it was that it could be done, and talking to the people themselves was really the number one thing. So we did a needs assessment, essentially, and I can't show you all because it was very detailed, but what we did know was that initial demographics, about 61% of individuals were people of color, so Black, Latinx, other folks. The remainder of folks were white individuals, mainly men, most people English speaking, and age between 35 and 44 years of age, median age. So most of these people, more than 60%, lived in a tent in the area for greater than 1 year. So this is a long-standing, this is like what we call chronic unsheltered status, chronic homelessness. And when we said, you know, well, what services do you have? You know, what is it that you need? So I was surprised, well, maybe I wasn't surprised. So more than 60% were engaged in primary care. So most of them were being seen at Boston Healthcare for the Homeless or at BMC. Half of them were engaged in medication for opioid use disorder. So the methadone clinics, where there are 2 of them. A lot of folks who were living out there, you know, utilizing those services. Others engaged in a substance use service, very few engaged in mental health services. And we do have the Department of Mental Health who's out there. We have psychiatrists who are out there. But just sort of a lack of service provision, relatively speaking, considering how sick this population really is. I mean, you have people who, many of whom, you know, have had opioid use disorder for a long time. You know, we have other contaminants in the drug supply and other things that are happening out there. Lots of underlying mental health disorders. Clearly, lots of issues. When we surveyed them and we said, well, what is it you really need? Housing, by far, was the number one concern. So we said, these data have to lead what we do next. And so what we did was we created structural change. We said, we're going to do housing first. And we are going to assume that housing is healthcare. We are going to look at it as the number one strategy that we are going to use to address this issue. So that meant immediate access to housing without condition. You don't have to stop using, you don't have to do anything, you don't have to have your paperwork, because that's a huge issue. There's nothing you have to do. We're not doing Corey check, we're not doing anything. You get immediate access to housing. Harm reduction and medical care at that housing. There's some choice. That was a difficult one, but this is all part of housing first. There has to be some sense of determination, self-determination. Social and community integration. So it's obvious that what was happening out there and what's happening now, it's a community of people. And that's why a lot of people stay in the area. And then recovery-oriented supports for those individuals who really wanted to enter recovery, but there was no, impetus, no pressure to do so. So we established 6 what we call low threshold housing sites across the city of Boston, place-based, meaning that they were in 4 different neighborhoods. Low threshold housing, as I said, there are no entry requirements. We just put people where we thought they wanted to be and, you know, where they felt most comfortable. Some of them single room occupancy, hoteling, some of them cottages, some of them, you know, shelters as we look at shelter transformation. And quite honestly, this was a big deal. You know, it was a big deal nationally. A lot of people are not doing this. This costs a whole lot of money. And I have to be honest, I'm not sure how long, I'm not sure exactly how long we're going to be able to maintain this. This is the kind of system change that you would like to maintain. Hopefully we'll be able to maintain it as we move into thinking about other opportunities, whether it be, you know, sort of Long Island or other, you know, places where we can think about expanding communities of people who need these types of supports. So we worked with Congresswoman Presley to secure another grant, to secure a separate grant, to actually look at issues of equity as we're doing this. Because interestingly, what you find, and I bet most of you all would guess this, is when you institute new programs and you put money towards something, because of the way our systems work, oftentimes they're inherently inequitable. You know, you have money going towards individuals, people, populations, not necessarily the people who need it most, but that is just the way it happens. We wanted to make sure that that did not happen in this case. So we got an additional grant, and thank you again to Congresswoman Presley for helping us with this, so that we would be partnering with communities, we would be ensuring equity, and that we would be planning for sustainability. Like I said, sustainability is the key thing. Don't know, I can't speak specifically on and definitively how we will be able to sustain, but we're moving towards that. And it's definitely one of the intentional aspects of the program. So just looking at our initial equity analysis, you know, there wasn't a significant difference in terms of the people who were out in the tents who were placed. You know, 58% of the Black individuals, 51% of Latinx, 61% of white individuals. There wasn't a significant difference in where they were placed in terms of whether they got a cottage or they got a single room or they got a, you know, sort of the shelter piece of it. But for me, that, you know, that's important, because it talks about access to services. But what's really important is what happened once they got into those spaces. What is it that changed? What is it that they felt that was different? So we did a 3 to 6 month evaluation, and then we have a longer term evaluation that's underway using the federal funds that I mentioned. So I'm going to briefly and quickly review just a little bit of the 3 to 6 month data. And it's really just frequencies, but I think it is important for us to kind of get a sense of how this particular program changed how these people live. This is our recovery services team, not all of them. Obviously, it's a lot of them. We call them the red shirts, except for that white and that blue shirt. Red shirts, they're really great. They're really great guys. We have a lot of women out there also who are just out there on a daily basis working with people. And they actually moved, or they were the major movers of people from those initial tents into these new housing opportunities. So just a big thank you to them as they, you know, do the hard work on a daily basis. And I talk about it. So towards the future, just want to say, we need to be continuing our support for the programs that I mentioned. I don't want to undercut. Those programs are really important. They meet the immediate needs. They meet the individual level needs. They are very important for people across the city of Boston. But we do need to shift our focus to these structural place-based interventions. If we want the tide to shift, if we want the gap to close, if we want the next Health of Boston to look differently, we need to do something different. Certainly community leadership and empowerment, I don't think you can understate that. It has to happen. It's really critical. And I keep saying this word sustainability, but it worries me when we do things and then 2 years down the line, we're like, oh, money ran out. You know? So we constantly have to be thinking about sustainability. So I do sort of end things by saying, you know, we need a call for sustained action, sustained momentum in order for us to deal with all the challenges that we're currently facing as a city, as a state, you know, as a country. So I'll end there. I think I ended right on time. Okay. So thanks, everyone. Are there any questions or thoughts? Oh, Sabrina, can I go to Sabrina? Hey, Dr. Asamu.
With your question, but you know, I go to a lot of health equity. Oh, sorry.
Well, thank you. So, sorry, thank you for a really phenomenal talk. I mean, we go to a lot of health equity talks, and I really love the fact that now we're shifting to structural change and addressing the real drivers, with addressing wealth and economic mobility. The health equity accelerator, actually BNC did the same. Actually the first panel was talking about economic mobility. So thank you. Anyway, I'll let someone else ask the questions.
Hi. Hi, this is so interesting, and thank you for coming and talking to us about this. I have two questions. One is, all this amazing work that you've done and the people that you help to house, is the population down on Atkinson and around Mass and Cass less than it was, or have new people kind of moved in to take their place? So that's just one question. And then the other is, I live near Franklin Park, and of course the talk in the neighborhood is now, the BMC deal and all these new structures. So how do we, the people there don't feel like this is place-based community, right? So how do you, how do we talk to these people and kind of get on the same page about mission?
So the first question we get asked all the time. So yes, it's new people. More people have come from other places. There are a lot of services in the area. And quite frankly, and we've said this in the media, there's an open air drug market. And people are addicted, and they're addicted to substances that they're injecting or using frequently. So they're not going to necessarily expand, go a lot of other places. So it's new people. So we have to figure out new strategies for new people. And we're working right now to figure out what we can do next. So that's a little bit of an open-ended question. In terms of the community response and the Shattuck proposal, I can't say a lot specifically because we're actually, in that negotiation process. But what I would say is that I've sat in on some of those community meetings just to hear, what's going on. And I think that there's a very high level of stigma, a very negative perception, and a lack of understanding that substance use disorder is just another chronic disease. That's what it is. It's a relapsing, recurring chronic disease. I don't know what it's going to take our society to get there, because there are a lot of people with lived experience who are talking about substance use disorder. There are a lot of people who I think are speaking up more about their own, not only their own experience, but the situations they've gone to, and the fact that there are people who may be addicted or maybe using actively, but they're still able to work. They're still able to be productive individuals. There are a lot of people who go on to recovery and are still able to work, but it is a relapsing, recurring chronic disease. And I think there has to be a shift in that thinking for us to get to the point where we're accepting of people being in close proximity to us who happen to be using. That's a big shift. It's huge, not only in regards to the kinds of low threshold housing placements around the city, but as you think about overdose prevention sites and things of that nature. There are a lot of people, a lot of neighborhoods that just would not tolerate that within close proximity to where they live. No answer there, but it is certainly a major concern. Yes.
Good morning. My name is Catherine Gergen Barnett. I'm Vice Chair of Family Medicine. Just also want to thank you for your beautiful, important words and work. The piece that you highlighted again and again is shifting power from institutions to communities, which is, I think what so many of us are thinking about, especially as we're doing the work on research and data. I am very curious. I know the Department of Public Health has, with this, talked about how to build trust with the communities. And I am wondering if you could address that and also talk about how we as institutions can be partnering with you to do that work.
So trust is a huge issue. And I guess I'll preface it by saying that a lot of my research before coming to this particular job was looking at issues of trust and engagement and care, particularly for individuals living with HIV. I think the trust starts with transparency. And our systems aren't transparent. It's very rare that you get people telling the full story. I think we saw that during COVID-19. I think we see it on a daily basis. There's a hesitation to give all the information to people, as if people can't take it, or as if we just want to hold back and not tell people, hey, I don't know the answer to that. So it begins with transparency. It begins with being accountable for the things that you're saying that you're going to do. Knowing that, okay, now I said that we're doing this health equity zones project. project. So we have to come to something that has to come to fruition in some way, even if it's a small way, or I have to explain to people why it didn't happen. People need to see us, I don't care, black, white, whoever you are, as somebody who will tell the entire truth. So I think that's a really important piece of it. I think it's also about acknowledging that trust is not a one-way street. It's not that they don't just, and I say they and us, I just institutional. So they don't trust us. We don't trust them. Please. Just honestly, we're not giving people the benefit of the doubt when it comes to funding. We often say, well, they don't have the history, they don't have the infrastructure, they can't manage $100,000. There's a lack of trust there, and it's definitely bidirectional. And that's something that we're writing about with some other folks who do public health, because that's a major issue when you're talking about getting large sums of money from the federal government and then it just trickling out. As opposed to really going to communities. So those are just some thoughts that I have, and I'm sure there are lots of others. But in terms of partnering with us, we obviously partner with BU, the School of Public Health, with BMC, and looking for more partnerships. We do want to make that academic public health connection. Please just reach out, and we'll figure out ways to work closer together.
I have a question as well.
Oh.
Hey, Dr. Ojikutu, how you doing? Thank you so much for your amazing talk today. And I really appreciated just hearing your perspective on how policy change can be a lever to moving towards sustainability and structural interventions. And the question I had for you was around the omnibus bill you mentioned a bit earlier, and this idea of creating health equity zones that really empowers the community and really community-based organizations to do a lot of the work around organizing and providing services to folks. So my question was like, how is that looking on Mass and Cass, for example, where you have folks coming to provide food or thinking about ways to meet those needs to the various organizations that they have and are a part of in that setting?
So that's a good question. I think that, obviously, Kareem, I think one of the things that you've been doing with your program and other people have been trying to help out on Mass and Cass. And I think it's important to, as I stated, or as I call this lecture, collective action, that we're all working together on things. I think it's sometimes a bit of a struggle because you have people who are trying to do good things, not knowing how exactly to do it in that setting. And sometimes it just needs to be coordinated, so that everybody, everybody can be a part of this. Is a huge issue. I think everybody can be a part of it. It's just about coordinating the effort. And it is about figuring out what the people down there want. You know what I mean? I mean, right now, the tents haven't been dismantled. Nothing new per se has happened recently. So you do have a community of people. And what is it that they want most? A lot of them have said to me, we want more bathrooms. Okay, we need to figure that out, because that's not, as you all probably know, that's not what's happening. We don't have a lot of bathroom access. Is it food necessarily? Or is there, food inside of our shelters? And can we, make sure that food is the right food or safe food for folks? So I think there's just a lot of pieces to this puzzle. So I hear your question. I think a lot of us can work together on it. It really is just about coordinating it and kind of doing it in ways that meet the needs of and are safest for the population.
Thank you.
Yeah. How do we compare to other cities of our size, and what lessons that they've been successful, can we steal from them to be able to be more successful?
Yeah, that's a great question. I won't just compare to cities our size. I'll just talk about the cities I think have been progressive, and have been doing things that I think are relevant for us to learn from. So first of all, overall, when you look at that life expectancy particularly, it's better than a lot of cities. The 80.2 that is across Boston. It's when you get down and drill down into the census tracts. And like I said, you have the 69 in the census tract that's near Roxbury, and the 23-year gap across 2 miles. That we see across the US. But there's some cities that have been very proactive and have done the things that I've already mentioned and done it well. So one of which is Chicago. So they noticed a 30 some year life expectancy difference between the west side, where, you know, is very, I'm originally from Chicago, from the south side, but the west side, resource limited, you know, lots of concerns, issues, violence there, and the downtown area. So between those two, about a 30 some year life expectancy difference. This was years ago that they noticed it. And what they did was they basically brought together a multi-sector coalition. So not just the hospitals like we do, those of you who know the CHIP, the Community Health Improvement Plan, not just the hospitals, not just the academic centers. I mean, they really brought together development corporations, the finance folks, the life insurance folks, you know, they brought them, the funders, they brought them all to the table and said, we got to do things differently. So they had buy-in to do that. And there's actually going to be a panel session that I'm going to moderate next month about that. I'll get that information to the committee because I think some people here might be interested, but they're going to talk firsthand about what they've done differently. But one of the things they did is they really had true buy-in to work together to achieve this. You know, I think that a lot of people around Boston care. What we do need to do is coordinate more together, you know, to really attack one or two specific issues. I think a lot of us want to do this, this, and that's wonderful. I think we have a wonderful resource-rich city. The coordination amongst those entities doesn't always happen. And I think people are aware of that. It's something we're working on.
Hi, I'm Hugo Aparicio. I'm a stroke neurologist here at BMC. My research is on cardiovascular disease prevention and brain health and Alzheimer's disease and related dementias. And I was just struck by a lot of the trends that you're looking at and the outcomes that you're looking at. You're trying to look over just a few years, 5 years, 15 years. For a lot of the diseases that I treat, the impact won't be seen possibly for decades. And so my question is just how do you convince policymakers that the work that you're doing now is necessary, but you may not be able to see the impact until you know, even the next generation, so that data is not going to be immediately available to show the fruit of your work?
I think that's a great question. It's tough. I think that's the answer. You know, it has been very difficult to even move the needle. By moving the needle, I mean bringing us together with the political will, the interest around life expectancy, you know, even though, you know, I think we put out compelling data, it was all over the media, it's been very difficult. But what it takes is community. It takes people who are interested. It takes us to continue to talk about it. It makes it higher on the priority list. I don't know that we all know the power that we have, you know, and even whether it be, you know, if you're living in that neighborhood or you're living in any other neighborhood, it's like, wait a second, this is important. Why isn't anybody doing something about that? So that is part of the issue. And I think you're hitting on something that's very important, is that we can't look at 5-year outcomes in this data. You know, the fact that they were putting these Health of Boston reports out every year, I'm not sure if that's really, you know, I don't know if that really makes sense. We're working on kind of deciding what we're doing moving forward. But we do need to be thinking about the fact that we can't always say, you're going to get these results before your next election, you know, and that might help your election. You know what I mean? It really has to be a bigger, broader, the moral imperative to get this done.
You mentioned that a lot of people don't feel as safe. So I'm just wondering if there was a measurement of violence that occurs in these communities, both towards them and within them. And it also has an association with substance use. And if there are any measures or services in place that you have added after looking at this data.
So the original survey, we did several point in time surveys from 2021 through 2022, and then we started individual sort of case management. But we did ask a question about safety in the area, sense of security. We asked, I think, 2 questions about that. So most people didn't feel safe. Most people feel like violence has increased, you know, in that time period that we were surveying, it's increased in the area. And that is why people may turn to drug use. You know, either they're using stimulants to stay awake so that they don't, you know, they aren't victimized, or there's something, or they're numbing themselves, you know. So it's not that substance use necessarily always precedes unsheltered status. I mean, oftentimes people end up on the street for a variety of different reasons, and then they end up using substances to, in a sense, protect themselves, if you want. And I think that, if you will, and I don't think that people recognize that. So in terms of things that we've done differently, out on Atkinson Street right now, we had to hire our own security team. And the security team, is one that is, we've tried to pick one that we felt was, competent, meaning, they understood that population to a certain extent. I have to say it's tough. They may not always do the best things, but I do think they have made it somewhat safer out there. But I think the other piece of this is that from our standpoint as a city, the tents need to come down. Things have gotten out of hand. Okay, so I understand that people, many people feel like people are taking away their housing. I understand that. But where we're at right now, this is a problem. And we're working towards hopefully being able to move people into safer, secure housing. So it's at 10 o'clock. Can I take one more or no? One more. Okay. Yes.
Good morning. My name is Wizan Duni. I'm over here.
Oh, okay, sorry.
It's okay.
Okay, no, I'm sorry. You're okay. Okay, I'm sorry. Okay.
Recently in the news, they found a toddler.
Yeah.
And the tent and that community. How are we surveillancing, or what are we planning to do to make sure that a toddler is no longer found there?
So I appreciate you mentioning that. I think that a lot of things happen in the chaos that is that tent area and the quarter-mile radius around Atkinson Street. That was a very unfortunate event. The toddler was subsequently, and the parent were subsequently moved out of the area and, provided with some additional assistance. In terms of preventing that, there are no gates. It's not a gated, area. People can do whatever they want. You have to keep in mind that there are 2 methadone clinics. So people are coming because they need to. And sometimes they don't have childcare. That is happening. I see it. I've seen it happen. That situation was more, you'd have the child being there overnight. So we have spoken with our security teams, with BPD, who are out there, and they've increased their presence. We've also spoken with our red shirts and other people who we have there to ensure that that doesn't happen. And we do have cameras in the area. We are surveilling it. So I appreciate you bringing it up. We're doing our best. I think it's tough. Thank you.